Good
afternoon.
Okay.
All right, I think we should get started.
Okay, business faces.
So welcome to today's session, Updates from Washington, D.C. with the NKF Government Relations. My name is Lekha Tamalapalli. I'm a nephrologist and health policy researcher at Weill Cornell. 2025 and 2026 have been a time of remarkable advancements in kidney health. New models of care, ways to diagnose and treat kidney disease are accelerating faster than ever, and yet there are fundamental threats to kidney care and research, which is why the work of policy and advocacy has never been more important to ensure that our patients have access to the quality of care that they deserve. So in today's panel discussion, we'll provide updates in kidney health policy. We'll discuss how these policy changes will affect us and our patients. These are our learning objectives, and I'm truly honored to welcome today's panelists, our four outstanding panelists from the National Kidney Foundation, and I'll have you introduce yourselves. So Dr. Jesse Roach.
Hello, I'm Jesse Roach. I'm the Senior Vice President for Government Relations at the National Kidney Foundation. I'm not sure what it says up there about me.
Your policy win.
Okay, so I have been here about 2 years. I previously worked at CMS and the FDA, among other things, and I'm a nephrologist as well. And it is great to be here.
I'm Lauren Drew. I'm the Senior Director of Congressional Relations, so I scream into the void for a living. We're supposed to talk about our policy wins. Do that now? Yeah?
Yeah, that would be
Oh,
great.
I didn't know we were supposed
We wanted
to.
to start on a positive note, and so there's been a lot of achievements and advancements in the past year, and so we asked everyone to highlight one of their policy wins. So,
Okay.
Dr. Roach, do you
I'll
want
just
to?
start with mine.
Yes.
Sorry, I thought we were going to do introductions first. So our policy win is the expansion and the sort of continued expansion of the OPTN reform. I think this has been a big policy and advocacy what's the word I'm looking for? A big policy and advocacy priority for us, and we've started to see a lot of movement on it. We've seen it get appropriated money, and impetus and inertia continue towards it, and they're also taking in a lot of our input, such as on things like patient transparency and discard prevention, et cetera. So I think this is one of the big things where we've been helpful for patients.
Great, thank you, Dr. Roach. So moving on to Lauren Drew, can you tell us a little bit about your role at NKF and also your policy win? And in fact, you have multiple wins on the slide, so please tell us about them.
Yes. So as I said, I'm the lobbyist, essentially, for NKF. And while I was joking about screaming into the void, I'm actually very passionate about democracy and participatory government. And so before I give you my wins, I wanted to ask a couple quick questions. Show of hands, how many of you actually know who your representative in the U.S. House is? Cool. If you are a U.S. citizen and you don't know, that's your take home. How many of you know what district, what House district you are? Great, okay. How many of you know if that is changing? For some of you it is, and for some of you it's not. How many of you know when your next primary is? All right, so this is a decent crowd. Okay, so all right, good, I'm glad. Because that's what I was gonna say. If any of those questions, made you go deer in the headlight, that's your homework. That's the baseline of being a productive and participatory member of democracy. Because trust me, it does work if people show up, but the people who have been showing up are maybe not the ones we would like to be showing up. So everybody here, get that baseline information, know when your voting is, know who your member is.
I would like everybody to show up.
But in terms of wins, the reason why I listed several things on mine, is because despite what you might read in the headlines, we're actually getting a lot of really good things done. They might be quiet, they might be behind the scenes. But for example, in a world where a lot of funding was cut to zero, we actually preserved a lot of it. Not that it was perfect. I know there's still probably some of you out here who had your grants pulled back and who had impacts to their programs. But comparatively to the rest of the world, the fact that a lot of our programs still exist is a pretty big win. The Living Donor Protection Act is the furthest along it has ever been. It has passed out of the committee in the Senate, which is huge. So that's a pretty big win for us. And Congress is just really focused on kidney issues right now. There have been a whole lot of hearings, a whole lot of white papers, a whole lot of briefings. So, that can be a double-edged sword if you're getting a lot of attention. But for us, in terms of making sure they understand the importance of kidney health in the whole nationwide ecosystem of health, that's pretty good. So it's not all bleak.
Great. So Miriam Godwin, can you tell us about your role at NKF and your win?
Sure. It's so nice to see so many friends and colleagues out in the audience who I love working with on these issues. So thank you so much for being here. My name is Miriam Godwin. I'm the Vice President of Health Policy here at the National Kidney Foundation. So I work with a great many of you on all kinds of health policy issues, particularly different regulatory policy issues that can seem sometimes really in the weeds or almost boring. But I would agree with Lauren. These things, they move the needle, they transform care, they change the context in which care is delivered for the people that we care about so much. And I'm so gratified to do this work and tell you all about how important it is. My win for the year has been working with actually some of my friends and colleagues from CMS who are in the room to talk about moving value-based care further and further towards earlier stages of chronic kidney disease, and to talk about screening and diagnosis and early intervention and preserving cardiovascular health, and having a different conversation about the transformative effect that we can have on the lives of people affected by kidney disease if we just act earlier. And it's been really gratifying to do that.
Thanks, Miriam. And Carson Smith.
Bear with us while we play hot potato with the mic. Carson Smith, I'm a policy analyst with NKF. I'm relatively new, so if this is the first time you're seeing me, that's because I joined NKF in August. Come meet me after this. I like meeting new people. I would love to meet you. So my policy win is working with the Public Policy Committee that we have. It's a really great group of perspectives from all over the interdisciplinary team, including patients, which in my opinion are the center of the interdisciplinary team and a major part of that team. And this group is just fantastic. I love getting to work with them, and in particular we have an ESRD subgroup which I'm working with to really identify policy solutions for all things ESRD, and I have loved getting to work with this group in my time with NKF, and I'm really excited for what the future holds for that group and how we can kind of turn these policy recommendations into actual policy wins so that I can share that with you in the future.
Great, so let's dive right in and talk about the coverage landscape. So we know that this time was a massive upheaval in terms of, particularly in the Medicaid program. So Lauren, could you talk about the One Big Beautiful Bill Act?
Yes. So I'm not going to call it that. We do call it OBA for short because it's a long name. Oh, sorry. I'm not loud enough naturally. But so Medicaid, what we're talking about here really is like the 40% of kidney patients that are dual eligibles. Those patients that they might be getting a majority of their services through the ESRD benefit, but they are also getting wraparound services and other services through Medicaid. For us, we've been trying to focus on 4 major areas where we think these patients might be at risk for states that have to change their program to conform to the changes required in OBBA, OBA. Major one for us is the medical frailty exemption, and that is exempting patients from some people call it work requirements, some people call it community engagement requirements, but OBA does require any Medicaid patient to have X number of hours of work, basically work or volunteerism. And as we know, for a lot of our patients, that would basically be impossible. So we are trying to make sure not only ESRD, but where possible, recent transplant recipients and late stage CKD would be eligible for the medical frailty exemption. That's partially a federal thing, so we are waiting for the feds to come out with their definition of what that is. But in the meantime, some states, if you're in Nebraska, they launched on May 1st with all of their changes. So some states are not waiting, and they are interpreting it differently. To making sure that we're reaching out to as many states as we can, small team, to advocate for our patients and why they should be eligible for a medical frailty exemption from those work requirements. Secondly, a lot of states are being asked to change their frequency of determining your eligibility for Medicaid. Some states are doing it quarterly now, and that can be a really big paperwork burden for our patients. We've seen in some states that already instituted this that a lot of patients did lose access to Medicaid, not because they were not medically eligible, but because they did not file their paperwork on time. So trying to advocate for automatic redeterminations based on their medical records as opposed to having to continually report new paperwork. And then just, again, tracking, because it could be different in different states. That's the beautiful but complicated thing about a state-based policy like Medicaid, is that California is going to do it very different from Texas, is going to do it very different from Maine, is going to do it very different from Florida. So that's where we need y'all out there in the states to tell us, what are you seeing? What are you hearing? Because you might hear about it before I do in Washington, D.C., and then you can tell me, we need to get a letter out to Idaho. We need to get a letter out to Nevada. So those two are probably the biggest issues, but two other small ones. Non-emergency medical transportation for dialysis. Not saying that the non-emergency medical transportation program doesn't have its warts, but a lot of our patients do rely on it. So making sure that that benefit is still going to be available. And then also the caregiver exemption. There is a caregiver exemption for caregivers of chronically ill patients to also not have to comply with the work requirements and community engagement requirements. A lot of our caregivers don't know that. So how can we make sure that that family is getting those benefits and getting access to those? So those are the four, I mean, there's other issues, but those are the four issues in Medicaid that we are worried about for our patients. And I guess my ask of all of you is please keep your ears to the ground and tell us what you're hearing so that we can then advocate and help you advocate and help the local offices advocate on these issues.
I just wanted to add one thing. The rule from the federal government is expected June 1st. So look out for that date. And in Nebraska, you mentioned, I would say that it's good that they decided to exempt stage 4 and stage 5 and ESRD patients from the paperwork requirements. So that hopefully will be a good omen for what's going to come next, but we will just have to wait and see.
Thank you both. So is your anticipation that ESRD is going to be explicitly mentioned in the June 1 requirements, that it's exempt from the it's part of frailty, or is it going to be up to the states to decide?
No, we would like to see a federal level exemption of individuals with ESRD and hopefully with later stages of chronic kidney disease as well, blanket exempted due to the complexity of the condition. I don't think we can anticipate what is in there. We are hopeful. We're really, really hopeful. But we're going to wait and see.
Great. So a lot more to talk about that. Please do enter your comments and questions in the Q&A in real time. I'll be monitoring this, and we can ask them to the panelists. And at the end, we'll take questions from the microphone here. So let's move on to talk about early CKD screening and diagnosis. So I know this is a key priority of NKF for several years, and NKF has done so much in this area. So Miriam, do you want to kick us off and tell us about some of the recent things that you've been working on?
Sure. So I often, thank you. So I often, people will come to me and say, why is it so hard to get chronic kidney disease screened and diagnosed? Why are we dealing with this as the foundational issue that underpins everything else we want to do? And so we continue to work with the body known as the U.S. Preventative Services Task Force, along with our friends and colleagues from the American Society of Nephrology, the American Kidney Fund, the American Association of Kidney Patients. Everyone really would like to see endorsement of CKD screening by that body. That body governs what primary care in family medicine prioritizes around screening for conditions with no signs or symptoms, which we know that is definitionally kidney disease. I'm happy to chat with anybody about it later. I want to kind of save the time, but the USPSTF is always in a state of flux. We don't exactly know what's going to happen with it, but we are continuing to make the case that there is real value to screening these patients. We happen to be focused on screening for individuals with risk conditions like diabetes, hypertension, family history, et cetera. So we're trying to unlock that. We also, I kind of made a joke earlier about quality measures. That is another tool that we use to get people at risk screened and diagnosed. NKF is the steward of the quality measure kidney health evaluation for adults with diabetes. That is the annual kidney profile for people with diabetes. We do all kinds of advocacy for that measure to get that included in federal and non-federal health programs. Again, it seems really weedy and boring, but it does drive screening. I mean, this is the issue that we have to solve, is how do we get the urine sent out, the UACR documented in the medical record, and the diagnosis of kidney disease documented and acted upon. And when we can solve those issues at a system-wide level, then we're going to start to see the transformation we want to see. NKF does a lot of this work through our Coalition for Kidney Health, and that's also the group that we do all of our value-based care work on. So, it's nice to have the quality measures, but you have to have the program too. And so as we think about what is the future of primary care, we want to make sure that we have the policy framework, but we also have the tools that are going to drive the transformation that we want to see and the behavior change that we want to see. So it would be so great if we could unlock USPSTF, but in the meantime, we're using every other tool we can.
Great. And there may be a huge change on the horizon for the KED measure. Is that right?
Absolutely. So we actually just, for those of you who know that measure, I don't think she's in here, but our colleague Elizabeth Montgomery just submitted that measure, an expansion to the denominator to include hypertension, which is a huge deal for us. Again, it seems really small, but its quality measures are tough. It's a long journey to do that. It's a huge journey to make changes, but it is going to drive behavior change across the country. It's an incredibly powerful tool, and we're really excited to build on that. Not only to do the screening, but to do the diagnosis, to do cardiovascular risk reduction, and to identify rapid progressors. I always say no one's going to throw a party for quality measures, but sometimes that's the tool you have. And we've got to figure out how to use it in the way that is the best steward of the resources we have and what our patients need.
That's very well said. Lauren, do you want to add to this?
Yeah, let me jump in and talk. So some of what we're doing, obviously this is what the work that Miriam and Carson do is really in the administration, in the regulatory space, but then you have the side of Congress, right, where some things have to be done just because of legality, have to be done via legislation. And so one of the things we're working on is a kidney disease education bill. So expanding the existing kidney disease education benefit to upstream, so all stages of CKD and patients who have diabetes or hypertension diagnoses, expanding the universe of who can provide KDE education, and getting rid of the 6-session limits. The bill also talks about getting kidney disease screening in not only into the Medicare, like Welcome to Medicare visit and the annual wellness visit, but also into private insurance, and basically taking that kidney disease education as opposed to mostly modality training, focusing more on preventing progression, early intervention, and then also maybe a little bit of managing your transplant, like healthy living on a transplant. So this bill has gone through many, many iterations. Thank you to those of you. I know several people in the audience have given us feedback on this and helped us to really hone it and make it what we hope will be a really, really impactful bill. So fingers crossed, I am hoping for that introduction sometime this summer. But if you know anything, the average bill takes about 7 years to pass Congress, so these things don't happen overnight. But the more we talk about it, the more you guys tell your congressman that, hey, there's this bill out there, it's going to do this. This would be great for patients in my state and at my hospital. That's how things get elevated from just one of the 10,000 bills that get introduced every year, some of whom are absolute wastes of ink, and then some of whom are absolutely essential. How is a member of Congress going to know that unless they have heard from their people, their constituents, that, hey, this bill is important to me? So I'll tell you more about this later, but we have the ability for you all to reach out to your members of Congress on bills like this and tell them, yeah, this matters to me, this matters to my patients, let me tell you why. So we're super excited about that one. I also wanted to very quickly just flag, as I mentioned before, the funding for CKD research, kidney research, and surveillance that we've at least protected. We advocate every year to increase funding, but in the current environment, just protecting the funding we have has been a really big win. So the ongoing CKD surveillance activity and public health work, making sure that patients can get access to screening at federally qualified health centers, rural health clinics. How can we use technology to get over barriers about why people aren't getting early diagnosis? And that's just, done in many different ways in the federal government, but continuing to fight for that funding and to explain to them why this is important is, well, this isn't wood, but knock on wood, so far has been going well.
Yeah. Carson.
Yeah, I'm just going to add to what Lauren said about working on things that we know are important for our patients. One thing we've heard a lot about is phosphorus labeling, and it's something we're working on. We've built the case on why we think phosphorus should be added to the nutrition label, both added phosphorus and total phosphorus. And we think it will make a difference for ESRD patients for sure, but also patients with CKD and even people that are typically otherwise healthy. It's an important thing, and we're trying to find avenues. That's kind of everything we do, is how can we get this policy idea implemented? So whether that's talking to the FDA, talking to other people, and how can we actually make this happen? But it falls into that category of what's important for our patients, and we really do want to hear from you in terms of what you think is important if you're a patient, or for your patients, what is important. What can we do to help make your lives easier? And then it's kind of, like I said, our job to figure out how to make that actually happen.
Great. So before we move to talk about research funding, there was a question about whether providers would have to recertify patients, to certify patients for the medical frail exemption for the work requirements.
Yeah, so it's interesting. I think we're waiting to see what's going to be in the interim final rule. There are two policies at play. One is what categories of individuals are going to be kind of considered medically frail, and then also how often that has to be recertified. And so it doesn't help a lot, right, if you're blanket exempted, but you have to reconfirm it every month. That just goes back to the paperwork burden, something that is going to be completely unrealistic and for someone with chronic illness to manage. So we're waiting to see. I don't have an answer yet, but we have our fingers crossed that there's going to be some coherence to that policy, and that our colleagues in the federal government understand that having the exemption alone is not as powerful as having the exemption and also exempting these individuals from continuous recertification requirements.
The SSDI, I think, is every 7 years, and so we are hoping that if we get a determination of, ESRD, it is not going to all of a sudden get better, that we can get a nice long period of time so they're not constantly recertifying. And in a perfect world, it should be able to be done via medical records and not resubmitting fresh paperwork. But again, we're going to have to see what they come up with, and then we're going to have to see how the states interpret it. So again, please pay attention to what your states are doing. Some states have already said they're going to go stricter than what the federal government says. Based on the law, you can't be weaker than, but you can be stricter than. So pay attention to what your state is talking about, what your state Medicaid agency is talking about. I know there are some states that we're talking about quarterly recertifications, and no, we're not going to do it automatically, and no, we're not going to look at the database, and you're going to have to do forms every month, and that's going to be rough. So that's where we need not only the patients to say something, but the providers who are going to have an incredible paperwork burden to also stand up and say something. So set up that Google search, your state, Medicaid, and just stay on top of it, which I know in the other 23 and a half hours of your day of other important things you do, but hopefully this would be like a 5-minute thing.
So thank you all for your great questions in the Q&A. A lot of them tackled the dialysis reimbursement. So we're going to talk about research funding next, and then spend a lot of time answering some of these questions. So in terms of research funding, many of us in academia and beyond have known that this has just been such a tumultuous time in research funding with changes to the NIH. A lot of us have been part of grants that have been put on hold, have been terminated, have been reinstated. There's a lot of uncertainty. So tell us a little bit about NKF's perspective on this and how we're moving forward. Jesse, do you want to start?
Sure. So this is a pretty big problem. And NIDDK is the National Institute of Digestive and Diabetes and kidney diseases. I think I might have got it mixed up, but you get the idea. NIDDK is the most important funder of kidney disease. And there's just a lot of uncertainty around the funding and funding mechanisms around that. And in a lot of ways, it's not the amount, but it's the stability and whether you can count on that. So some of the things that they've done are just there's uncertainty around sort of what they're going to do about indirect costs and where that's going to end up, and so that's going to decrease the amount of money that's available. Doing multi-year grants, which makes the money not necessarily available over the full 4 years of the grant. These are sort of things that we've heard a lot of our people at the academic centers are worried about. There's also delayed study sections, slowed grant processing, grant terminations, followed by litigation, followed by grant reinstatements, then followed by terminations, reinstatements, and that's no way to run a lab. And so what happens with that is you have delayed hiring, you have delayed people that are delaying research careers or ending research careers. We're potentially going to lose an entire generation of researchers because they can't count on funding and they can't count on a steady paycheck. And so I think this is going to end up delaying clinical trials, which is what's really important to have, to grow and to have innovation in the kidney space. So, and then on top of that, kidney disease is already pretty underfunded compared to other specialties. And so I think this is a pretty dire moment. It's just very difficult to plan for sort of transformative change when there's no stability in funding. So we have been working with a number of organizations. ASN has been one of the people who have taken the forefront, and we've worked very closely with them on protecting kidney research. We've come up together with a proposal that we have given to policymakers. We're fighting very hard to preserve both the funding and to get rid of the uncertainty around funding, because again, that's in many ways more damaging than the lack of funding, even though lack of funding is important. The good thing is that research is still pretty much a bipartisan supported thing. Most people like research, and also all of these research jobs are in somebody's district, and so no one wants to cut bunches of jobs. The level of NIH funding has been preserved relatively well throughout this, and this is something that we've been advocating for, and we just need to make sure it stays at that level and that level of kidney funding is commensurate with the amount of innovation that we've seen in the past 10 years. So that's one of the things that we're very cognizant of, and we love to hear from people that are having research problems and having their grants cut. We are very receptive to that. We have our medical leadership who's also keeping us in the loop on these things, but then any other times when you hear about things, please let us know.
Yeah, I'm just going to echo that. We absolutely need to know because, like, I'm on the Hill and I'm talking to Congress all the time, and I do get questions from members of Congress saying, "Have you heard of any cuts at my university, in my district? You know, is there anyone in the kidney space who's having problems with this?" So if you tell me, then I can go back to them and say, "Yes, actually, let me connect you with this researcher who's having this problem." But I need y'all to tell me because I'm not out there and I don't know. So if you or a friend or anyone is in that space having those problems, even if you're not totally sure or you don't have all the details or you're not, look, tell us about it anyway, and we can chase down, you know, what the issue is, and at least advocate and let that member of Congress know, yeah, this is impacting your district and people who work at your universities. The other thing I just wanted to flag is the appropriations process is complicated. And just because you hear that, oh, the administration wants to cut X number percent and the administration's budget eliminates this program and blah, 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 the administration does not actually have the power of the purse. Congress does. That is in the Constitution. So the administration, and this is for any administration throughout history, they can send a budget to Congress. They can absolutely send a budget to Congress. They always do. It's considered a wish list. Generally, Congress looks at it and goes, ha, that's cute, and throws it in the waste bin and then does their job. So just don't panic when you hear headlines about, oh, administration demands, 50% cuts at NIH. Okay, they can demand all they want. Last time, Congress did not take 94% of the suggested cuts that the administration wanted. I saw the same thing this year when the administration's budget came out. They were calling for program eliminations, and we got to fight for it. We have to tell our members of Congress why we don't think those programs should be eliminated or why we don't think there should be a reduction in funding. But there's an old saying, in Congress, there are Democrats, Republicans, and appropriators. Appropriators generally take their job very seriously, regardless of if they are of the same party as the person in the White House or not. They take their responsibility as the people who determine the funding very seriously, and they do not like being told by the White House how they should spend money. So we have an opportunity there, and again, if you have built those relationships or are willing to start those relationships with your member of Congress and tell them, hey, did you know that in your district there's all this research happening? There's all these programs that are funded and they're in your district. Why don't you come out and visit them? Let me show you what my lab is working on, and make it personal for them so they're willing to fight for it if they get a letter from the administration saying, we don't like this program, it's stupid, we're going to cut it. Then you have a friend there who says, actually, this employs X number of people in my district and they do really good work, and no, I'm not going to put them on the cut list. But just don't get scared by the headlines. And again, if you do and you see something, you're like, oh my gosh, this sounds really bad, you can email us and I'll chase it down for you and let you know if, yes, you need to worry, or most likely, don't worry.
Lauren, how should we reach your team?
We're just first name dot last name at kidney.org.
Oh, okay. Is that the best way, or is there a policy email? Or?
So I have another slide on this, but we're actually launching a Kidney Professionals Advocacy Committee. So if you're interested in getting a little bit deeper into this is just an interest form. You're not signing your life away. You're just saying, I might be interested in this thing. But doing that also puts you on our email list. We send out an email once a month with here's the big news, here's what's going on, and you'll be able to contact us through that. But for congressional stuff, you are welcome to email me, lauren.drew@kidney.org, and if I don't have the answer, somebody will.
We're all pretty open, so you can email all of us.
Yeah.
The one thing I want to add about the president's budget, while it is not law, it does signal what the administration thinks is important. So it is important for us to see what's in there. And when they say they want to cut 50% from biomedical research, it means that they don't value biomedical research. And so you then see them doing these things that maybe they can't mess with the appropriations, but they can cancel grants and make it harder and slow processing and do things like that. Take away the staff that makes the grants possible. And so we have to also watch out for that aspect of it, which we do. And that's just saying, just take part of that as this is what the administration thinks. And that's what we do. So.
There is a question about kidney research funding outside of the NIH and NIDDK, including the VA and DoD. Any changes there?
So CDRMP, congressionally mandated research program, has a lot of rare kidney research. We do work very often with our friends at ASN and NFCure on some of those very specific CDRMP defense funding programs that get really into like the very specifics. I know we were doing one on IgAN and one on, what was the one that just came through? Anyway, we keep tabs on those and make sure we're working with whatever organization's specialty that is. For VA, similarly, that appropriations process is a little bit different because it doesn't go through the health system, it goes through the VA. We're very lucky that generally VA funding is not something that's up for debate. We keep tabs on that to make sure that that is not something that is up for debate, but we are pretty lucky so far that that has not necessarily had the same level of scrutiny that we've seen of NIH and even of CDC. CDC also has the CKD initiative and other kidney projects there that we have definitely been trying to keep funded, even though the current administration has certain views of the CDC. They're not very interested in funding a lot of things at CDC, but we at least kept the stable funding for the CKD initiative. I have heard rumors that there are other things going on at CDC, so if you have heard that too, please let me know. I'm still trying to chase it down. But there are disparate kidney programs kind of all over the federal government. And again, if you have a special interest in a special part of those, please let us know, and I'm happy to give you like the full update on your specific piece of that.
I also just want to add, we've had some success. A number of companies we work with have gotten grants through ARPA-H, and so I think that's going to become a potentially increasing level of kidney disease research funding.
So in our remaining time, we're going to talk about dialysis and transplant. So let's talk about dialysis first. And we know that the ESRD bundle is under pressure. There's increasing attention and acknowledgement that the dialysis payment system is under need for reform. So let's actually start with some of these questions from the group. Because I think it speaks to a lot of these issues. So the first is about phosphorus binders being covered for CKD patients. And we can't get phosphorus binders covered by Medicare since they've been added to the dialysis bundle. So how do we fix this? And that was a question from multiple folks.
Yeah.
And is that referring to dialysis or CKD patients?
CKD-free dialysis.
Oh.
Covered by Medicare?
Yeah, so since it got added to the bundle, insurers, especially the Medicare pharmacy benefit manager, have taken note that it is technically off-label to use the phosphorus binders pre-dialysis. And therefore, they are not being covered. So if my patient is not on dialysis, I'm having to have them go through cost-plus drugs and not use their insurance in order to obtain Sevelamer or any of the other binders.
I would love more information about
Yeah,
that.
we actually hadn't heard that, so that's really helpful to know. This actually this is a kind of a perfect example of, we're very accessible. I think sometimes I know it can feel like when you're dealing with like a society or a patient group that it feels like, oh yeah, they tell us that like they're accessible, but they're not really accessible. And I would emphasize that we are like very accessible. There are a great many people in here who are friends of mine because we talked about like an issue they had on kidney Twitter in 2019. And now they're like someone that I would write into my will. So we're very, very accessible. Please tell us about issues like this. This is super helpful. I don't think we can answer right now just because we would need more. We'll need more information, but we'd love to help.
Has anyone else experienced this?
Let me just add one more layer to that. So yes, I'm aware of that concern, but I'm in dialysis However, my patients that are supposed to get it through like commercial insurance and get it outpatient, the pharmacies are not carrying binders and telling me that it's because patients are supposed to get it through the dialysis provider.
Yeah, that
I've heard.
Another route, right? So that as well.
Okay.
Yeah.
Yeah.
Yes.
Absolutely.
So this is a post-transplant problem as well, right? I mean, some of our patients require these medications after transplant, they're not in dialysis treatment. We have the same problem with bundle issue, exactly the same issue.
Wow. All right.
Okay, well, this has been enlightening.
Yeah, that's
Email
very
us.
helpful.
Yeah, well, send us this
So
because we're
there's-
going to have to take it back and look at it.
There's another question about advocacy to expand the coordination of benefits period from 30 months to 36 months. That would reduce so much distress for patients.
The coordination of benefits.
Yeah, from 30 to 36 months. And the questioner, you can feel free to add more about why that's distressing.
Yeah, please.
So after transplant, I'm a little transplant-centric back here, sorry.
No.
After transplant, if you're previously transplanted, you're entitled to ESRD
Yeah.
Medicare for 36 months.
Yeah,
It causes a nightmare
I know.
for patients that are preemptively transplanted because the 30-month coordination of benefit issue forces them to have to purchase Medicare Part B.
Yeah.
They purchase Medicare Part A at
Yeah.
the time of their transplantation when they're initially entitled, then they get penalized 10%.
Yeah.
For every month they don't, or every 12 months they don't have Medicare Part B, which they have to enroll in by the 30th month before it terminates on month 36. It's a crazy policy.
Yeah, actually, I do know about this, and this is also going to be a learning exercise for the audience. So we're going to get your email, and then we're going to ask you to put down this problem in a 2-paragraph item, and then it's going to go on our wish list of items for the next transplant bill that we write. And so you've just watched our policy
Congrats, you've
process
made
in
policy.
action. Congratulations.
It's not that easy. We will consult other people as well.
Right. But this is how it happens. Actually, this is a really great example.
Yeah.
Thank you for flagging. I do know this issue. And I think that it's very much worth raising because, I know many of you, we've talked about, what can we do from a policy standpoint to try and emphasize the importance of preemptive transplant. And a lot of people, like some members of our public policy committee who are here, we've had this conversation many times, right? And what are the barriers, the addressable barriers around preemptive transplant? This is a great example. Another one is, the patient who becomes Medicare eligible the month of the kidney transplant and then can't get the workup because the Medicare has not kicked in until the month of the transplant. And when they walk in with a GFR of 20, they're not Medicare eligible, and we can't prove that they will be. So this is enormously helpful. Thank you so much. Thank you for participating in NKF Public Policy. Great job, 20 out of 10. And yeah, we'll take it back.
Yeah, that's we are. I don't know where you're located, but anyone who lives in Congresswoman Gwen Moore's district, she's particularly passionate about this. And so we've been working with her office for several years to try and find ways to increase access to preemptive transplant and generally improve the transplant ecosystem for patients. And that is how bills can happen. She had a personal experience. I met her at a fundraising reception. We had a conversation, and then we wrote a bill. So sometimes you don't know if your members of Congress have a personal connection to these issues, and all they need is your expertise to be like, oh, here's a thing we could fix. And it becomes a thing. So I see Mary nodding her head because you know exactly how this works.
Yeah, you could talk to Mary Valacher about this.
So we have a few more things on your to-do list for things to do. So one question is, why is there a 10% Part B premium penalty when enrolled in ESRD Part A when creditable coverage is in place? It's different for when people qualify for age and disability.
That's a good question.
So I guess...
Is that also
My question.
Yeah, I don't know the answer
No,
to.
it's a stupid policy.
Yeah.
I'm sorry, I'm judgmental as well as transplant-centric.
Oh, we can be friends.
Yeah.
The rules are different for ESRD Medicare, SSDI eligibility, and age for this issue. It just doesn't make sense. And I'm super curious as to why it is. It really should change.
Yeah, I don't have an answer. I don't know the why. Some of these things are
They weren't all done at the same time, and people
yeah,
weren't
like
talking to each other.
Yeah, and but no one has raised that one in a long time, and it is really it's helpful. Thank you for raising it again. I actually will ask. I will ask around and see if I can find an answer. But I agree with you that it's very confusing. And, at various points, we've talked to folks from like the Medicare Rights Center, so people who do counseling for Medicare beneficiaries who will call and say, I need help figuring out how to enroll, or something's gone wonky with my part, questions exactly like you're raising, like why is there this penalty around the enrollment time? And they will even tell us, right, like ESRD is very confusing. And I think we understand that it is a real morass for people to navigate. And enormously grateful for the wisdom of the social workers, the wisdom and the passion of the social workers who do this for the people that we serve. You all are on the front lines, and you work miracles, and we're enormously indebted to you.
And many of you have helped us write these bills.
Yeah.
And what is the premium penalty exactly? So they have to pay more for Part B premiums?
Yeah.
I see. And there's a couple of questions about coverage for uninsured patients. So both for outpatient dialysis, as well as how do we get uninsured patients in dialysis clinics to unload the burden of dialyzing them in the hospital? Just anything about uninsured patients.
I will tell you that
We were making good headway on that.
well, that was, yeah. I mean, I will tell you that I do occasionally get a phone call saying I have an uninsured patient and I need a dialysis chair, and it is unbearably difficult. I don't think I've ever resolved it once. And if I think have tried really hard in an environment where Medicaid was sort of expanding and not contracting, to make sure that there is at least minimum emergency Medicaid available to people who are otherwise don't have access to insurance, so that there is some possibility that a facility will dialyze them. It's hard even with emergency Medicaid because the reimbursement is so poor. I wish, I can't tell you how much I wish that I had a magic wand for that one. It's really hard.
And I mean, especially, I was thinking specifically about undocumented patients, and that we had made some good headway on getting them EMTALA, but in the current situation of making sure, like, it might not even be safe for them to be in a facility.
Yeah.
So
I mean, I will say that for those of you who know or have worked with Dr. Lily Cervantes, that she has done extraordinary advocacy work by making this exact case that dialyzing patients with in the hospital on an emergent basis is incredibly inefficient. It's terrible quality care.
And it's extraordinarily expensive.
And it's extraordinarily expensive. And so that argument works. It has worked. It can work again. I think it's very hard in this particular political climate. But one thing about politics is that it comes in waves, and we will be in a different time. And to the extent that you are looking for access to emergency Medicaid, I would keep a flag in your brain that it worked once and it will work again.
Carson, did you have additional comments about the dialysis bundle?
Yeah. So happy to share what we've been working on with the Public Policy Committee. I'm going to continue to brag about them because they are a fantastic group of individuals. But what we're looking at is pretty much anything related to ESRD we want to kind of improve. So that's home dialysis, that's the bundle, that's innovation, TDAPA, TIPNIs, and it really runs the whole gambit. I think like what I'm most excited for is home dialysis and improving home dialysis and access to it. And because of the improved quality of life for patients on home dialysis, trying to figure out how we can get them to make that transition, feel comfortable in that transition, and then make sure they're successful in home. So we have things we're looking at, like improved education, improved regulations and structure of how dialysis is paid for to make it easier for these patients to be on home. Things like staff-assisted home dialysis. We're really looking at anything we possibly can to make that a reality. In addition, things like innovation. How can we make sure that new and innovative drugs and devices are paid for and reimbursed, and reimbursed in a sustainable way, so not just paying for anything, but paying for what works and paying for what drives positive outcomes, and what matters for patients, right? So if it's a patient-reported outcome, that's something we really care about. I want to flag that the Ways and Means Committee in the House has recently been thinking more about ESRD and the bundle, and that's kind of proven by a recent committee hearing on ESRD and the bundle, and it was really great to get to see that. We keep our ears out for anything related to kidney, but then to have something like that where it's like blockbuster of the week, like kidney hearing, it was really cool.
How many of you know your member of Congress is on the Ways and Means Committee?
Oh, that's a good question.
Yeah, okay, Mary, yes, I know you know. The rest of you, that's your next level, right? If you know who your member of Congress is, figure out what committees they're on,
Yeah.
because you could have been testifying. They ask constituents to come in and testify at hearings like that. But you got to be connected, you got to know who they are, and they need to know who you are.
Yeah. So it's nice to know that both within the administration and on the Hill that there's interest in improving the bundle and improving ESRD care. So, I mean, it kind of just shows how much of policy nerds we are, but we get really excited about that kind of stuff. But I think we're searching for headwinds, and we're doing the work with, like I said, the Public Policy Committee to kind of identify where we want to point the ship, and trying to make sure that we're ready once that opportunity comes up to kind of enact these policies, have an opinion, be a part of democracy, like Lauren loves to be, loves to get everyone involved. I think you're saying is. Policy
Decisions are made by those who show up. Yeah.
Decisions are made by the people that show up, and we're really trying to make sure that we show up for the patients with the patients, making sure they're involved every step of the way in how we develop our policy stances. So I'm really excited with what we have going on in bundle reform, and I am very glad to be working with NKF and Government Relations, and it's very exciting.
You can tell he's new. He's not jaded yet.
Yeah.
So let's end to talk about transplantation. So much happening with OPTN modernization. There's been scrutiny over organ procurement, New York Times articles, the first value-based payment model in transplantation. So a lot to discuss. Miriam, do you want to kick us off and talk about OPTN modernization?
Sure. So I think we only have 8 minutes. There's no way that I could cover sort of everything that is going on in the transplant system, but I will just try and, the modernization initiative is essentially a way to, it's such a I don't mean to say it's like it's a very wonky way to describe what we're trying to do with transplant modernization, which is essentially to enable the government to buy different services to support the organ procurement and transplant network. So that includes organ procurement organizations, transplant centers, actually organizations like NKF, histocompatibility labs, and many other types of organizations. And when I say like the services the government buys, again, it's like, oh, cool, that sounds super fascinating. But it's actually very, very relevant, because that's all technology. That's all technology that underpins how the transplant system functions. So, I mean, imagine the pace at which we are learning about transplant immunology. and how we can make increasingly better matches of organ to recipient, and the incredible complexity and the incredible amount of code that requires to take the, hundreds of thousands, the 250 million people registered to be organ donors, the people who ultimately, become organ donors, have organs procured, are donated, and then need to find a match among the 90,000 plus people waitlisted for a kidney transplant. All of that's driven by computer code. And we need to be able to buy technology that enables that kind of computer code to be able to keep pace with the rapid innovation that we see in transplant immunology and transplant science. And so, yes, I think, government procurement seems dreadfully boring, but it really matters a lot because, that's the bread and butter of government work in a lot of ways is can we buy the newest and the best? Can we use the tax dollars that we all pay to buy the best technology to do the best that we can for patients? The modernization, again, terrible word. It also just includes, little things that, again, seem small but are important, like what is the structure through which policy is made? If any of you have participated in kind of the OPTN committee process, you'll know that it moves like molasses. It is really, really, really slow. So can we think differently about governance so that we can move, more quickly from idea to policy to implementation? How are the tax dollars that we pay for this used? Right? Are they used to support staff? Are they used to support committee meetings? What should they be used for? And, again, it seems dry, but it's not, right? All of these things have real implications for how the system runs and how patients interact with it.
And data availability?
Data availability, that's another huge, there are so many things that we don't understand because we don't have system-wide data that tell us what the gaps are. So how many, I think all of us, right, who work on transplant at one point or another have said, what is the time from the first call to a transplant center to the determination that's made about waitlisting? Anyone think that we have system-level data on that? We do not. You do not know. And there is no public data on that. And so when we talk about modernization, it means what about hiring the staff that can support the writing of a Paperwork Reduction Act notice to collect data from the public and send it to the Office of Management and Budget and clear it and implement it. That's going to move the needle because one day we'll be able to tell patients your time from calling the transplant center to waitlisting is 3 weeks here and it's 10 days here and it's 6 months here. And that will make a real difference for somebody who's navigating that journey. But it starts here. I'm happy to just pivot to questions if people have questions about transplant. I would say we're also really closely looking at value-based care in transplant.
I wanted to turn to that, actually. I see some of our CMS colleagues in the audience. Can you all comment on the IOTA model or other models, many of which have focused on transplant? And do we think IOTA is going to move the needle in terms of number of transplants? Is number of transplants the right metric? Would love to hear your thoughts.
Sure. So that model, the IOTA model, increasing organ transplant access, came out of I think, a multi-year conversation about how many organs are procured for transplant here in the U.S. that are not used. So we call that non-utilization or discarded organs. It's a discordance, essentially, between the organs that we actually go out and procure and the patients that make it onto the transplant wait list. So the organ supply has changed. We are not talking about a necessarily perfect kidney, but not everyone needs a perfect kidney. And so what we're trying to do is to try to create some kind of an understanding that shared decision-making is real, that as you spend more time on the list, your preferences can change, your willingness can change. I can't tell you how many people I talk to, kind of off the record, patients I talk to who say, I won't make it one more day on dialysis. I won't make it one more week on dialysis. And that's someone who has a very different risk tolerance from someone who got on the wait list yesterday. So that's really what we're trying to do with that model. I think that this is our first pass at value-based care and transplant. My huge kudos to our CMS colleagues. You can't imagine how thankless building and running value-based care models is. If you haven't tried it, I encourage you to go sit in Baltimore or Washington, D.C. and try it, because it will very much change how you think about these things. Nothing's perfect on the first try. Policy is a process, change is a process. I think we sometimes have an expectation that, policymakers have like a magic wand, right? And everything's going to be perfect and not subject to constraints. That's not how it is. We try things, we iterate, they work, sometimes they don't work, and we keep trying, and that's how change happens. So this is the first time we're trying, and we're going to learn, and we're going to iterate, and we're going to keep learning, and that's because we know the status quo isn't good enough, and the only alternative is to change. It's to try something different.
So, a lot that we did not cover, many questions related to Medigap coverage that varies by states, policy efforts to finance hemodiafiltration and dialyzers. Carson touched upon that a little bit in terms of innovation. And then a really big question about, as clinicians and the public lose more and more trust in our institutions, how can NKF and should change its approach to advocacy on behalf of our patients? So I think a lot of unanswered questions. I really do invite you all to come up. Please. We could talk about this for the next 5 hours, and we will. So thank you all for your engagement, and really thanks to the hard work from the NKF Government Relations team, and for your remarks today. Thank you.
I didn't get a chance to do my plug, but in terms of how we're changing advocacy, we are specifically trying to incorporate more of the professionals and providers in our advocacy. We've done a great job engaging patients, but we need the voice of the other people on the ground delivering this care, seeing how these systems work or don't. So if you're at all interested in learning more, again, you're not signing up for anything other than to indicate to me that you might be interested. The QR code is here. We'll have like some calls and some conversations about what it's going to look like. We will make a selection of a really small group of to get us started, probably 20 people, maybe 30 people. So if you're at all interested, please sign up via the QR code. And we're gonna build a specific advocacy team of providers to make sure we are trying to fill those gaps, get to those questions that we're not hearing about. And if you have ideas on how we should build that, please let me know, because we don't do anything without talking to y'all and the patients first. That's where we get our marching orders from. So whether you like what we're doing or don't like what we're doing, please tell us so we can iterate. Thanks.